Hi friends, welcome to PharmaGrid. So today we are going to learn about arrhythmia. So in this video we mainly discuss about the conduction system of the heart, how an action potential is generated, what is arrhythmia and what are the different types of arrhythmia and what all are the treatment options. So first of all we need to learn about the conduction system of the heart and about the autorhythmic fibers which are responsible for the heart's electrical activity. An inherent and rhythmical electrical activity is the reason for the heart's lifelong beat. The source of this electrical activity is a network of specialized cardiac muscle fibers called autorhythmic fibers. They are known as autorhythmic fibers because they are self-excitable. Autorhythmic fibers repeatedly generate action potentials that trigger heart contractions. They continue to stimulate a heart to beat even after it is removed from the body. For example, to be transplanted into another person and all of its nerves have been cut. The normal cardiac rhythm, that is the sinus rhythm, is characterized by contraction of the first atria and then the ventricles. So this contraction is known as systole followed by relaxation. Relaxation is known as diastole, during which the heart refills with blood before the next cardiac cycle begins. So this orderly sequence of contraction and relaxation is regulated by the heart's electrical activity. We have seen that these autorhythmic fibers are self-excitable. During embryonic development, only about 1% of the cardiac muscle fibers become autorhythmic fibers. And these fibers have two important functions. First one, they act as a pacemaker. That means setting the rhythm of electrical excitation that causes contraction of the heart. And the next function is to form the cardiac conduction system. It is a network of specialized cardiac muscle fibers that provide a path for each cycle of cardiac excitation to progress through the heart. The conduction system ensures that cardiac chambers become stimulated to contract in a coordinated manner, which makes the heart an effective pump. Now we'll see in detail about the cardiac conduction system. So this cardiac action potentials propagate through the conduction system in a particular sequence. Okay, so which consists of certain steps, and the first step is the cardiac excitation. Normally begins in the SA node. SA node is known as the sinoatrial node. It is located in the right atrial wall, just inferior and lateral to the opening of the superior vena cava. And the sinoatrial node is known as the natural pacemaker of the heart. SA node cells do not have a stable resting potential. Rather, they repeatedly depolarize to threshold spontaneously. The spontaneous depolarization is a pacemaker potential. When the pacemaker potential reaches threshold, it triggers an action potential. So each action potential generated from the SA node propagates throughout both atria via gap junctions in the intercalated discs of atrial muscle fibers. Following the action potential, the two atria contract at the same time. So the first step we have already seen. Okay, the cardiac excitation that normally begins in the SA node. And the second step is by contacting along the atrial muscle fibers, the action potential reaches the AV node or the atrioventricular node. That is the cardiac excitation that begins in the SA node, and the next step it will propagate into the or propagate through the AV node. Okay, AV node or atrioventricular node, and this AV node is located in the interatrial septum, just anterior to the opening of the coronary sinus. At the AV node, the action potential slows considerably as a result of various differences in cell structure in the AV node. This delay provides time for the atria to empty their blood into the ventricles. And the third step is from the AV node, the action potential enters the AV bundle, that is the atrioventricular bundle, which is also known as the bundle of His. This bundle is the only site where action potentials can conduct from atria to the ventricles. Elsewhere, that means in other places, the fibrous skeleton of the heart electrically insulates the atria from the ventricles. So far we have learned about the three sequence or the three steps that involved in the cardiac conduction system. So the first one is the SA node, second one is the AV node, and the third one is the bundle of His, or also known as atrioventricular bundle, AV bundle. Now moving on to the fourth step, after propagating through the AV bundle, the action potential enters both the right and left bundle branches. The bundle branches extend through the interventricular septum towards the apex of the heart. Then the fifth one, that is the final step. The large diameter Purkinje fibers rapidly conduct the action potential beginning at the apex of the heart upward to the remainder of the ventricular myocardium. Then the ventricles contract, pushing the blood upward toward the semilunar valves. So this is the sequence how the cardiac action potentials propagate through the conduction system. So the conduction system of the heart is again simplified here. Autorhythmic fibers in the SA node located in the right atrial wall acts as the heart's pacemaker, initiating cardiac action potentials that cause contraction of the heart's chambers. So we know that our heart has four chambers, that is right atrium and left atrium, right ventricle and left ventricle. And here they have mentioned the sequence how the cardiac action potentials are propagated through the conduction system. So the first one, the action potential initiation in the SA node or sinoatrial node, then through the AV node or atrioventricular node, then it propagates through the atrioventricular bundle, also known as bundle of His, then through the right and left bundle branches, and lastly through the Purkinje fibers. Okay, so this is how the action potentials are propagated. And here you can see a graph that's showing the action potential. Okay, so regarding the action potential, we will discuss in detail in the upcoming slides. On their own, autorhythmic fibers in the SA node would initiate an action potential about every 0.6 second or 100 times per minute. Thus, the SA node sets the rhythm for contraction of the heart. Hence, it is known as the natural pacemaker of the heart. This rate is faster than that of any other autorhythmic fibers. Because action potentials from the SA node spread through the conduction system and stimulate other areas before the other areas are able to generate an action potential at their own slower rate, the SA node acts as the natural pacemaker of the heart. Okay, so this is the reason why SA node is considered as the natural pacemaker of the heart. Nerve impulses from the autonomic nervous system and the blood-borne hormones such as epinephrine modify the timing and strength of each heartbeat, but they do not establish the fundamental rhythm. For example, in a person at rest, acetylcholine released by the parasympathetic division of the autonomic nervous system slows the SA node pacing to about every 0.8 second or 75 action potentials per minute. So now we will see how an action potential is generated. So action potential and the contraction of the contractile fibers. The action potential initiated by the SA node travels along the conduction system and spreads out to excite the working atrial and ventricular muscle fibers called the contractile fibers. So an action potential occurs in a contractile fiber as follows, or we can say that the action potential has got different phases, mainly phase 1, which is known as the rapid depolarization, and the phase 2, which is known as the maintained depolarization or plateau phase, and phase 3 is known as the repolarization. Okay, so first we will see about the depolarization phase. What will happen in the depolarization? So we know that similar to skeletal muscles, cardiac muscles also have a resting membrane potential of about minus 90 millivolts. So this means that the inside of the membrane is more negative than the outside. Unlike autorhythmic fibers, contractile fibers have a stable resting membrane potential that is close to minus 90 millivolt. So when a contractile fiber is brought to threshold by an action potential from neighboring fibers, its voltage gated fast sodium channels open. So these sodium channels are referred to as fast because they open very rapidly in response to a threshold level depolarization. So what will happen when an action potential is generated? Already inside the cell there is negative charge. Okay, it is under resting potential, resting membrane potential is about minus 90 millivolt. That means inside the cell there is negative charge. So when an action potential is generated, what will happen? The voltage gated fast sodium channels will open. We know that sodium ions are found more in the extracellular fluid, whereas potassium ions are found more in the intracellular fluid. So once this sodium channels open, what will happen? The sodium ions will get enter into the cell, making the cell charge positive. Okay, making the cell charge positive. So that will lead to depolarization. Okay, so these are all what happening in the depolarization phase. Okay, so opening of these channels, that means the sodium channels allows sodium inflow because the cytosol of contractile fibers is electrically more negative than interstitial fluid and sodium concentration is higher in the interstitial fluid. So inflow of sodium down the electrochemical gradient produces a rapid depolarization. That means the cell was already in the negative charge condition. Okay, so once the sodium ions get entered into the cell, it has become positive. Okay, that produces a rapid depolarization. Within a few milliseconds, the fast sodium channels automatically inactivate and sodium inflow decreases. So the next phase of an action potential in a contractile fiber is the plateau phase, or else we can say that it is a period of maintained depolarization. It is due in part to opening of voltage gated slow calcium channels in the sarcolemma. We know that this calcium concentration is found more in the extracellular fluid or the interstitial fluid. So this plateau phase is mainly due to, or in part due to, opening of the voltage gated slow calcium channels. So when these calcium channels open, what will happen? The calcium ions are already positive charge. So this calcium ions move from the interstitial fluid where it has got its higher concentration. So this calcium ions move from the interstitial fluid into the cell or into the cytosol. So this inflow of calcium causes even more calcium to pour out of the sarcoplasmic reticulum into the cytosol through additional calcium channels in the sarcoplasmic reticulum membrane. So the increased calcium concentration in the cytosol ultimately triggers contraction. Several different types of voltage gated potassium channels are also found in the sarcolemma of a contractile fiber. Just before the plateau phase begins, some of these potassium channels open, allowing potassium ions to leave the contractile fiber. As I have already mentioned, potassium ions are found more in the intracellular fluid or within the cell. So once these potassium channels open, what will happen? The potassium ions will move out or leave the contractile fiber. Therefore, depolarization is sustained during the plateau phase because there is already calcium inflow, calcium channels are opened, so there is slow calcium inflow, and there is also potassium. Calcium is coming inside whereas potassium is going out. So this phase is known as maintained depolarization because there is a balance. Okay, there is a balance. The calcium inflow just balances the potassium outflow. The plateau phase lasts for about 0.25 seconds and the membrane potential of the contractile fiber is close to 0 millivolt. By comparison, depolarization in a neuron or skeletal muscle fiber is much briefer, about 1 millisecond, or else we can say 0.001 second because it lacks a plateau phase. So in a nutshell, we can say that the phase 2, which is also known as maintained depolarization or the plateau phase, what will happen in this phase? This is mainly due to or partially due to calcium inflow when voltage gated slow calcium channels open and potassium outflow. Okay, so there is calcium inflow just balances the potassium outflow. So this is what is about the maintained depolarization or plateau phase. Now the third phase, which is known as the repolarization, the recovery of the resting membrane potential during the repolarization phase of a cardiac action potential resembles that in other excitable cells. After a delay which is particularly prolonged in cardiac muscle, additional voltage gated potassium channels open. Already some potassium channels are already open and there is potassium flow occurring, outflow occurring. So other than this, some additional voltage gated potassium channels will open. So outflow of this potassium restores the negative resting membrane potential, that is minus 90 millivolt. And at the same time, the calcium channels in the sarcolemma and the sarcoplasmic reticulum are closing, which also contributes to repolarization. So in repolarization, mainly two things are happening. So the first one is additional voltage gated potassium channels are opening, that will lead to outflow of the potassium and which restores the negative resting membrane potential. And one more thing, that is the closing of the calcium channels, which also contribute to the repolarization. And here the different phases of action potential are very clearly explained. So here you can see the three phases. This is the resting membrane potential. This is the membrane potential. The resting membrane potential is about minus 90 millivolt. At resting potential, a cardiac cell cannot initiate an action potential. And here you can see this is the first phase, which is known as a rapid depolarization. Rapid. Okay, see here you can see a steep response. This rapid depolarization is due to sodium inflow when voltage gated fast sodium channels open. Okay, so here sodium channels will get enter into the cell, making it more positive, which led to rapid depolarization. And here you can see the peak. And here there is a small decline. Okay, small decline is due to opening of the potassium channels. Okay, opening of the potassium channel. So there is some potassium outflow. Okay, some potassium outflow, which is mainly denoted here. And next is the plateau phase or the maintained depolarization phase. And this is due to calcium inflow. Okay, calcium is coming inside when voltage gated slow calcium channels open and potassium outflow when some potassium channels open. So here what is mainly happening? Here the calcium inflow just balances the potassium outflow. Okay, so this is the maintained depolarization or the plateau phase. And now it's declining, or it is known as the third phase, which is known as the repolarization. Repolarization is due to the closure of calcium channels. Okay, here the calcium channels will be closed, so there will be no more exchange of calcium ions and potassium outflow when additional voltage gated potassium channels open. So this is how, or what are the different phases of action potential. So the first one is rapid depolarization, second one is the plateau phase, and third one is the repolarization phase. So far we have learned about the conduction system, then about the action potential, how an action potential is generated. Now we will learn about arrhythmias. The usual rhythm of heartbeats established by the sinoatrial node is called normal sinus rhythm. Arrhythmia or dysrhythmia refers to an abnormal rhythm as a result of a defect in the conduction system of the heart. The heart may beat irregularly, too quickly, or too slowly. Symptoms include chest pain, shortness of breath, lightheadedness, dizziness, and fainting. Arrhythmias may be caused by factors that stimulate the heart such as stress, caffeine, alcohol, nicotine, cocaine, and certain drugs that contain caffeine or other stimulants. Arrhythmias may also be caused by a congenital defect, coronary artery disease, myocardial infarction, hypertension, defective heart valves, rheumatic heart disease, hyperthyroidism, and potassium deficiency. There are certain criteria for normal rhythm. So the first one is heart rate should be between 60 to 100 beats per minute, and the second one is action potential should be generated by SA node only. And the third one, the order of conduction should be the same that we have already discussed. That is from the SA node to the AV node, and from AV node to the bundle of His, then to the bundle fibers, and last to the Purkinje fibers. And the fourth criteria is that about the conduction velocity. That is the conduction velocity from SA node to AV node should be slow, whereas from AV node to bundle of His should be fast. Okay, so these are the certain criteria for a normal rhythm. Now we can see the types of arrhythmias. Arrhythmias are categorized by their speed, rhythm, and origination of the problem. So bradycardia refers to a slow heart rate that is below 50 beats per minute. Tachycardia refers to a rapid heart rate that is over 100 beats per minute. Fibrillation refers to rapid uncoordinated heartbeats. Arrhythmias that begin in the atria are called supraventricular or atrial arrhythmias. Those that originate in the ventricles are called ventricular arrhythmias. So other than this, PSVT, that is paroxysmal supraventricular tachycardia, here there will be rapid but regular heart rate about 160 to 200 beats per minute. Then atrial flutter. Here the heart will beat about 240 to 360 beats per minute. Here there will be rapid, regular atrial contractions accompanied by an AV block. Then atrial fibrillation. Here the heart will beat about 100 to 160 beats per minute. There will be rapid and irregular heartbeat. Then it is one of the most dangerous complication of this atrial fibrillation is stroke, because blood may stagnate in the atria and form blood clots. Okay, so the stroke is one of the important or dangerous complication associated with the atrial fibrillation. Then ventricular tachycardia. Here ventricles beat too fast, that is about 120 beats per minute, and this is always associated with a heart disease or recent myocardial infarction, characterized by 4 or more ventricular premature contractions. And the last one is about ventricular fibrillation, which is the most deadly arrhythmia. Here the ventricular contractions will be completely asynchronous. The most common cause of ventricular fibrillation is inadequate blood flow to the heart. It may be due to coronary artery disease, myocardial infarction, cardiovascular shock, electrical shock, etc. Now we will see about the causes of arrhythmias. Most arrhythmias arise either from aberrations in the impulse generation, abnormal automaticity, or from a defect in the impulse condition. So first one we will see about the abnormal automaticity. The SA node shows a faster rate of discharge than other pacemaker cells, and thus it normally sets the pace of contraction for the myocardium. If cardiac sites other than SA nodes show enhanced automaticity, they may generate competing stimuli and arrhythmias may arise. Most of the antiarrhythmic agents suppress automaticity by blocking either sodium or calcium channels to reduce the ratio of these ions to potassium. Already we have seen the action potentials. So what all are the ions involved in the action potentials? So these are the major areas where the antiarrhythmic agents will work. So that will be very easy for us to understand about the antiarrhythmic agents. So this decreases the slope of phase form, that is diastolic depolarization, and or raises the threshold of discharge to a less negative voltage, leading to an overall decrease in frequency of discharge. This effect is more pronounced in cells with ectopic pacemaker activity than in normal cells. And the next cause of arrhythmia is abnormalities in the impulse conduction. Impulses from higher pacemaker centers are normally conducted down pathways that bifurcate to activate the entire ventricular surface. A phenomenon called a re-entry can occur if a unidirectional block caused by a myocardial injury or a prolonged refractory period results in an abnormal conduction pathway. Re-entry is the most common cause of arrhythmias, and it can occur at any level of the cardiac conduction system. The short circuit pathway results in re-excitation of cardiac muscle, causing premature contraction or a sustained arrhythmia. So these anti-arrhythmic agents prevent re-entry by slowing conduction, that is mainly the class 1 drugs, and or increasing the refractory period, that is the class 3 drugs, thereby converting a unidirectional block into a bidirectional block. Coming to the anti-arrhythmic agents, these are the drugs mainly used for the treatment of arrhythmias. So the ultimate goal of anti-arrhythmic drug therapy is to restore normal rhythm and conduction to prevent arrhythmias or to reduce symptoms associated with the arrhythmias. So these anti-arrhythmic drugs are used to decrease or increase the conduction velocity, alter the excitability of cardiac cells by changing the duration of the effective refractory period, and suppress abnormal automaticity. Many of the antiarrhythmic agents are known to have dangerous pro-arrhythmic actions, which means to cause arrhythmias due to narrow therapeutic window. Inhibition of potassium channels widens the action potential and can thus prolong the QT interval. If prolongation is excessive, these drugs increase the risk of developing life-threatening ventricular tachyarrhythmias, which is known as torsade de pointes. So torsade de pointes means it is nothing but the QT interval prolongation. It is a special form of ventricular tachycardia, that is more time ventricle contracts and it takes more time to relax. So here what will happen? Inhibition of potassium channels widens the action potential, thereby prolongs the QT interval. Okay, so this is what happening in torsade de pointes. The most common cause of QT prolongation is drug induced, although other conditions, for example ischemia and hypokalemia and genetic abnormalities may contribute. So antiarrhythmic drugs are classified based on Vaughan-Williams classification according to their predominant effects on the action potential. Although this classification is convenient, it has some limitations. Antiarrhythmic drugs have multiple electrophysiological and pharmacological effects where their action relates to more than one class. This action depends on the route of administration, plasma levels and their active metabolites, which may have a different class of action or may have an action that does not meet any formal classification. Then examples of prodrugs among these antiarrhythmic agents are propafenone, quinidine and amiodarone. So what do you mean by a prodrug? Prodrug means as such it is inactive. Okay, once after the metabolism it will becomes active. Okay, so this is what is known as a prodrug. And here you can see the classification of antiarrhythmic drugs. So these antiarrhythmic drugs are mainly classified as class 1, class 2, class 3, class 4 and other antiarrhythmic drugs. So first one is class 1. Class 1 is sodium channel blockers. Again this class 1 is subdivided into 1A, 1B and 1C. So the drugs that comes under class 1A include disopyramide, procainamide and quinidine. Then 1B include lidocaine and mexiletine, and class 1C includes propafenone and flecainide. Then class 2. Class 2 includes mainly beta adrenoreceptor blockers or beta blockers. Examples are atenolol, metoprolol and esmolol. Class 3. Potassium channel blockers. Examples include amiodarone, sotalol, dofetilide, dronedarone and ibutylide. Then class 4. Calcium channel blockers such as diltiazem and verapamil. Other antiarrhythmic drugs include adenosine, digoxin, magnesium sulfate and ranolazine. So in this slide, you can see the treatment pattern. Okay, what all are the different types of arrhythmia and what all are the commonly used drugs for each types of arrhythmias. So first we will see about atrial arrhythmias, mainly involves atrial flutter and atrial fibrillation. So here those that are marked in black are the most commonly used drugs. In white, they are the alternative drugs. Okay, so in atrial flutter, class 2 and class 4 drugs are most commonly used. That is in class 2 metoprolol and class 4 verapamil. And the alternative drug option is digoxin. Then in atrial fibrillation, metoprolol and diltiazem and amiodarone are the most commonly used drugs. And also anticoagulant therapy is indicated in atrial fibrillation because thus stroke is one of the most dangerous complication of atrial fibrillation. Here the blood may stagnate in the atria and form blood clots. So the long-term oral anticoagulant therapy reduces the risk of stroke associated with the atrial fibrillation or flutter. That is why anticoagulant therapy is mentioned here. And the alternative drug options are propafenone, dofetilide and digoxin. Now moving on to the supraventricular tachycardias. First one is AV nodal re-entry. Here also class 2 and class 4 drugs, that is metoprolol and verapamil respectively, are the most commonly used drugs. Digoxin can be used as an alternative option. Then for the acute supraventricular tachycardia, here the drug of choice is adenosine and an alternative option is diltiazem. Now moving on to the ventricular tachycardias. Here implantable cardioverter defibrillators are commonly used to terminate ventricular arrhythmias. So in acute ventricular tachycardia, the first line treatment option is amiodarone, which is a class 3 antiarrhythmic drug. Lidocaine is an alternate option, which is a class 1 drug. Then ventricular fibrillation, not responding to electrical fibrillation. Here also amiodarone, which is a class 3 drug, then epinephrine. These two drugs can be considered as the first line options or commonly used drugs, and lidocaine can be considered as an alternative option. So if we examine, we can see that in general we can say that for atrial arrhythmias we are mainly using class 2 and class 4 drugs, whereas for ventricular arrhythmias we are mainly preferring class 3 and class 1 drugs. Then for paroxysmal supraventricular tachycardia, the drug of choice is adenosine, and for torsades de pointes, the drug of choice is magnesium sulfate. Now we will discuss each antiarrhythmic drugs in detail. So the class 1 antiarrhythmic drugs, they are known as sodium channel blockers. Okay, so from the name itself, it's clear that their mechanism of action is by blocking the voltage sensitive sodium channels. We have already learned about the action potentials and what is the role of sodium channels there. Okay, so hence the mechanism of action is clear. They bind more rapidly to open or inactivated sodium channels than to channels that are fully repolarized. Therefore, these drugs show a greater degree of blockade in tissues that are frequently depolarizing. This property is called use dependence or state dependence, and it enables these drugs to block cells that are discharging at an abnormally high frequency without interfering with the normal beating of the heart. The use of sodium channels has declined or reduced due to their pro-arrhythmic effects, particularly in patients with reduced left ventricular function and atherosclerotic heart disease. Then the class 1 drugs are further subdivided into 3 groups according to their effect on the duration of the cardiac action potential. Class 1A intermediate, class 1B fast, and class 1C, that is slow blockers of the sodium channel. Class 1A drugs. Examples include quinidine, procainamide and disopyramide. So here quinidine is the prototype class 1A drug. Because of their concomitant class 3 activity, they can precipitate arrhythmias that can progress to ventricular fibrillation. So this class 1 drugs have got class 1 activity. Along with this, they have got class 3 activity as well. Class 3 drugs, what they mainly do, they are potassium channel blockers. So let's see the mechanism of action. Quinidine binds to open and inactivated sodium channels and prevents sodium influx, thus slowing the rapid upstroke or the rapid depolarization during phase 0. It decreases the slope of phase 4 spontaneous depolarization, inhibiting potassium channels and blocks calcium channels. Because of these actions, it slows conduction velocity and increases refractoriness. Quinidine also has mild alpha-adrenergic blocking and anticholinergic actions. Although procainamide and disopyramide have actions similar to those of quinidine, there is less anticholinergic activity with procainamide and more with the disopyramide. Neither procainamide nor disopyramide has alpha blocking activity. Disopyramide produces a greater negative inotropic effect, and unlike the other drugs, it causes peripheral vasoconstriction. Therapeutic uses. Quinidine, though effective in the treatment of a wide variety of arrhythmias, including atrial, AV junctional and ventricular tachyarrhythmias, is used rarely due to its adverse effects. Procainamide is only available in an intravenous formulation and may be used to treat acute atrial and ventricular arrhythmias. However, electrical cardioversion or defibrillation and amiodarone have mostly replaced procainamide in clinical practice. Disopyramide is used in vagally mediated atrial fibrillation and in hypertrophic obstructive cardiomyopathy. It can be used as an alternative treatment of ventricular arrhythmias. Coming to the pharmacokinetics. Quinidine sulfate or gluconate is rapidly and well absorbed after oral administration. It undergoes extensive metabolism primarily via the hepatic cytochrome, that is CYP3A4 isoenzyme, forming active metabolites. Okay, so this quinidine is a prodrug. A portion of procainamide is acetylated in the liver to N-acetyl procainamide, which has the properties and adverse effects of a class 3 drug. This N-acetyl procainamide is eliminated via the kidney. Therefore, dosages of the procainamide should be adjusted in patients with renal dysfunction. Disopyramide is well absorbed after oral administration and is metabolized in the liver by CYP3A4 to a less active metabolite and several inactive metabolites. About half of the drug is excreted unchanged by the kidneys. Coming to the adverse effects associated with the class 1A drugs, mainly due to enhanced pro-arrhythmic effects and ability to worsen heart failure symptoms, they should not be used in patients with atherosclerotic heart disease or systolic heart failure. Large doses of quinidine may induce the symptoms of synchronism, for example, blurred vision, tinnitus, headache, disorientation, and psychosis. Drug interactions are common with quinidine since it is an inhibitor of CYP2D6 and P-glycoprotein. Intravenous administration of procainamide may cause hypotension and can cause drug-induced lupus erythematosus. Disopyramide has the most anticholinergic adverse effects of the class 1A drugs. So anticholinergic side effects mainly include dry mouth, blurred vision, urinary retention, constipation, etc. Both quinidine and disopyramide should be used with caution with potent inhibitors of CYP3A4. Moving on to class 1B antiarrhythmic drugs mainly includes lidocaine, mexiletine and phenytoin. Phenytoin is also an anti-epileptic drug. The class 1B agents rapidly associate and dissociate from sodium channels. Thus, the actions are greater when the cardiac cell is depolarized or firing rapidly. Then it is useful in treating ventricular arrhythmias. Mechanism of action, as we all know, they are mainly sodium channel blockers. In addition to sodium channel blockade, lidocaine and mexiletine shorten phase 3 repolarization and decrease the duration of the action potential. Neither drug contributes to negative inotropy. Coming to the therapeutic uses, although amiodarone is a drug of choice for ventricular fibrillation or ventricular tachycardia, intravenous lidocaine may be used as an alternative. Lidocaine may also be used in combination with amiodarone for VT stop. Mexiletine is used orally for chronic treatment of ventricular arrhythmias, often in combination with amiodarone. Then regarding the pharmacokinetics of class 1B antiarrhythmic drugs, lidocaine, also known as lignocaine, is orally not effective because of extensive first pass metabolism. So this drug is mainly given through the intravenous route because of the extensive first pass biotransformation by the liver. The drug is dealkylated to two active metabolites, primarily by CYP1A2 with a minor role by CYP3A4. Lidocaine should be monitored closely when given in combination with the drugs affecting this cytochrome P450 isoenzyme. Mexiletine is well absorbed after oral administration. It is metabolized in the liver primarily by CYP2D6 to inactive metabolites and excreted mainly via the biliary route. Now coming to the adverse effects, lidocaine has a fairly wide therapeutic index. Central nervous system side effects include nystagmus. It is an early indicator of toxicity. Then drowsiness, slurred speech, paresthesia, agitation, confusion, and convulsions, which often limit the duration of continuous infusion. Mexiletine has a narrow therapeutic index and caution should be used when administering the drug with inhibitors of CYP2D6. Nausea, vomiting, and dyspepsia are the most common adverse effects. Class 1C antiarrhythmic drugs. Examples include flecainide and propafenone. These drugs slowly dissociate from resting sodium channels and show prominent effects even at normal heart rates. Due to their negative inotropic and pro-arrhythmic effects, use of these agents is avoided in patients with structural heart disease. Examples include left ventricular hypertrophy, heart failure, atherosclerotic heart disease. Then coming to the mechanism of action, this flecainide suppresses phase zero upstroke in Purkinje and myocardial fibers. This causes marked slowing of conduction in all cardiac tissue with a minor effect on the duration of the action potential and refractoriness. Automaticity is reduced by an increase in the threshold rather than a decrease in the slope of phase 4 depolarization. Flecainide also blocks potassium channels, leading to increased duration of the action potential. Propafenone like flecainide slows conduction in all cardiac tissues but does not block potassium channels. It possesses weak beta blocking properties. Therapeutic uses. The class 1Z drug flecainide is commonly used to maintain sinus rhythm in atrial fibrillation patients. It is useful in the maintenance of sinus rhythm in atrial flutter or fibrillation in patients without structural heart disease and in treating refractory ventricular arrhythmias. Significant coronary artery disease is a contraindication to the use of flecainide and propafenone as it increases the risk of proarrhythmia and sudden cardiac death. Flecainide can be used on an as-needed basis in the outpatient setting. Use of propafenone is restricted mostly to atrial arrhythmias, rhythm control of atrial fibrillation or flutter, and paroxysmal supraventricular tachycardia prophylaxis in patients with AV reentrant tachycardias. Pharmacokinetics. Flecainide is well absorbed after oral administration and is metabolized by CYP2D6 to multiple metabolites. The parent drug and metabolites are mostly eliminated renally. Propafenone is metabolized to active metabolites primarily via CYP2D6 and also by CYP1A2 and CYP3A4. The metabolites are excreted in the urine and the feces. Adverse effects. Flecainide is generally well tolerated with blurred vision, dizziness and nausea occurring most frequently. Propafenone has a similar side effect profile but may cause bronchospasm and should be avoided in patients with asthma. Propafenone is also an inhibitor of P-glycoprotein. Both drugs should be used with caution with potent inhibitors of CYP2D6. Moving on to the second class, that is class 2 antiarrhythmic drugs, which are mainly the beta-adrenergic antagonist or beta blockers. Propranolol, atenolol, esmolol, metoprolol, etc. are class 2 antiarrhythmic agents. They block the effects of catecholamines on the heart with predominant action on the SA node. They decrease the heart rate, decrease automaticity by depressing the phase 4 depolarization, depress AV conduction by prolonging the refractory period and decreasing the conduction velocity, decrease the cardiac contractility. So they are useful in treating tachyarrhythmias caused by increased sympathetic activity. They are also used for atrial flutter and fibrillation and for AV nodal reentrant tachycardia. In addition, beta blockers prevent life-threatening ventricular arrhythmias following a myocardial infarction. Metoprolol is the most widely used beta blocker for the treatment of cardiac arrhythmias. Compared to non-selective beta blockers such as propranolol, it reduces the risk of bronchospasm. It is extensively metabolized by CYP2D6 and has CNS penetration, less than propranolol but more than atenolol. Esmolol is a very short and fast-acting beta blocker used for intravenous administration in acute arrhythmias that occur during surgery or emergency situations. Esmolol is rapidly metabolized by esterases in red blood cells. As such, there are no pharmacokinetic drug interactions. Common adverse effects with beta blockers include bradycardia, hypotension, and fatigue. Now, regarding the class 3 antiarrhythmic drugs, the examples mainly include amiodarone, dronedarone, dofetilide, and ibutilide. So they are mainly potassium channel blockers. So these drugs blocks potassium channels and thus diminish the outward potassium current during repolarization of cardiac cells. These agents prolong the duration of the action potential without altering phase 0 of depolarization or the resting membrane potential. Instead, they prolong the effective refractory period, increasing refractoriness. All class 3 drugs have the potential to induce arrhythmias. Now let's see about amiodarone. Amiodarone. So the one peculiar characteristic or feature of this amiodarone is that it contains iodine and is related structurally to thyroxine. It has complex effects showing class 1, class 2, class 3 and class 4 actions as well as alpha blocking activity. Its dominant effect is prolongation of the action potential duration and the refractory period by blocking potassium channels. Then regarding the therapeutic uses, Amiodarone has been a mainstay of therapy for the rhythm management of atrial fibrillation or flutter. Despite its adverse effect profile, amiodarone is thought to be the least pro-arrhythmic of the class 1 and 3 antiarrhythmic drugs. Amiodarone is effective in the treatment of severe refractory supraventricular and ventricular tachyarrhythmias. Coming to the pharmacokinetics of amiodarone, this drug is poorly absorbed after oral administration. It is highly lipid soluble and concentrated in many tissues. It has a long half-life, about 25 to 110 days, metabolized in the liver, and its metabolite is active. The drug is very slowly eliminated from the body. So the drug is unusual in having a prolonged half-life of several weeks, which is very important. Full clinical effects may not be achieved until months after initiation of treatment unless loading doses are employed. Moving on to the adverse effects. So the adverse effects of amiodarone is very important. Okay, so which includes pulmonary fibrosis, neuropathy, hepatotoxicity, corneal deposits, optic neuritis, blue-gray skin discoloration, and hypo or hyperthyroidism. However, use of low doses and close monitoring reduce toxicity while retaining clinical efficacy. Amiodarone is subject to numerous drug interactions since it is metabolized by CYP3A4 and serves as an inhibitor of CYP1A2, CYP2C9, CYP2D6 and P-glycoprotein. So the next class 3 antiarrhythmic drug is dronedarone. It is a benzofuran amiodarone derivative which is less lipophilic and has a shorter half-life than amiodarone. It does not have the iodine moieties that are responsible for thyroid dysfunction associated with amiodarone. Like amiodarone, it has class 1, 2, 3 and 4 actions. This drug has better adverse effect profile than amiodarone but may still cause liver failure. The drug is contraindicated in those with symptomatic heart failure or permanent atrial fibrillation due to an increased risk of death. Currently, dronedarone is used to maintain sinus rhythm in atrial fibrillation or flutter, but it is less effective than amiodarone. Sotalol. Although a class 3 antiarrhythmic agent, it also has non-selective beta blocker activity. Sotalol blocks a rapid outward potassium current known as a delayed rectifier current. This blockade prolongs both repolarization and duration of the action potential, thus lengthening the effective refractory period. So the levorotatory isomer, that is the L-sotalol, has beta blocking activity, whereas the dextrorotatory isomer, which is denoted as a D-sotalol, has class 3 antiarrhythmic action. And this drug is mainly used for maintenance of sinus rhythm in patients with atrial fibrillation, atrial flutter or refractory paroxysmal supraventricular tachycardia and in the treatment of ventricular arrhythmias. Since sotalol has beta blocking properties, it is commonly used for these indications in patients with left ventricular hypertrophy or atherosclerotic heart disease. This drug can cause the typical adverse effects associated with beta blockers but has a low rate of adverse effects when compared to other antiarrhythmic agents. The dosing interval should be extended in patients with renal disease since the drug is renally eliminated. To reduce the risk of pro-arrhythmic effects, sotalol should be initiated in the hospital to monitor QT interval. Dofetilide, which is a pure potassium channel blocker. It can be used as a first-line antiarrhythmic agent in patients with persistent atrial fibrillation and heart failure or in those with coronary artery disease. Because of the risk of proarrhythmia, dofetilide initiation is limited to the inpatient setting. The half-life of this oral drug is 10 hours. The drug is mainly excreted unchanged in the urine. Drugs that inhibit active tubular secretion are contraindicated with dofetilide. And the next class 3 antiarrhythmic agent is ibutilide, potassium channel blocker that also activates the invert sodium current. It has got mixed class 3 and class 1A actions. This is the drug of choice for chemical conversion of atrial flutter, but electrical cardioversion has supplanted its use. It undergoes extensive first-pass metabolism and is not used orally. Initiation is also limited to the inpatient setting due to the risk of arrhythmia. Now we will see about the class 4 antiarrhythmic drugs, which mainly includes non-dihydropyridine calcium channel blockers such as verapamil and diltiazem. Although voltage sensitive calcium channels occur in many different tissues, the major effect of calcium channel blockers is on the vascular smooth muscle and the heart. Both drugs show greater action on the heart than on the vascular smooth muscle, but more so with the verapamil. In the heart, verapamil and diltiazem bind only to open, depolarized voltage sensitive channels, thus decreasing the inward current carried by calcium. These drugs are use dependent in that they prevent repolarization until the drug dissociates from the channel, resulting in a decreased rate of phase 4 spontaneous depolarization. They also slow conduction in tissues that are dependent on calcium currents such as the AV and SA nodes. These class 4 antiarrhythmic agents are more effective against atrial than against ventricular arrhythmias. They are useful in treating reentrant supraventricular tachycardia and in reducing the ventricular rate in atrial flutter and fibrillation. Common adverse effects include bradycardia, hypotension and peripheral edema. Both drugs are metabolized in the liver by CYP3A4. Dosage adjustments may be needed in patients with hepatic dysfunction. Both agents are subject to many drug interactions as they are CYP3A4 inhibitors as well as substrates and inhibitors of P-glycoprotein. So far we have discussed about class 1, class 2, class 3 and class 4 antiarrhythmic drugs. Now we will see the other antiarrhythmic drugs that can be used for the treatment of arrhythmia. So among these the first drug is digoxin. So this digoxin inhibits the Na plus K plus ATPase pump, ultimately shortening the refractory period in atrial and ventricular myocardial cells while prolonging the effective refractory period and diminishing conduction velocity in the AV node. Digoxin is used to control ventricular response rate in atrial fibrillation and flutter. However, sympathetic stimulation easily overcomes the inhibitory effects of digoxin. At toxic concentrations, digoxin causes ectopic ventricular beats that may result in ventricular tachycardia and fibrillation. Now, the digoxin is a drug having narrow therapeutic window. Okay, so the concentrations or the trough concentrations has got its importance. Serum trough concentrations of 1 to 2 nanogram per ml are desirable for atrial fibrillation or flutter, whereas lower concentrations of 0.5 to 0.8 nanogram per ml are targeted for systolic heart failure. Now moving on to the next drug, which is adenosine. It is a naturally occurring nucleoside, but at high doses the drug decreases conduction velocity, prolongs the refractory period and decreases automaticity in the AV node. Intravenous adenosine is a drug of choice for acute supraventricular tachycardias. It has low toxicity but causes flushing, chest pain and hypotension. Adenosine has an extremely short duration of action, approximately 10 to 15 seconds, due to rapid uptake by erythrocytes and endothelial cells. And the next drug is magnesium sulfate. We know that this magnesium is necessary for the transport of sodium, calcium and potassium across cell membranes. So this drug slows the rate of SA node impulse formation and prolongs conduction time along the myocardial tissue. Intravenous magnesium sulfate is the salt used to treat arrhythmias, as oral magnesium is not effective in the setting of arrhythmia. Magnesium sulfate is a drug of choice for treating the potentially fatal arrhythmia, which is known as the torsade de pointes and digoxin induced arrhythmias. Moving on to the next drug, which is ranolazine. In the previous chapter we have seen that ranolazine is an anti-anginal drug. So this drug has got anti-arrhythmic properties as well, similar to amiodarone. Its main effect is to shorten repolarization and decrease the action potential duration, similar to mixilogene. It is used to treat refractory atrial and ventricular arrhythmias, often in combination with other antiarrhythmic drugs. This drug is well tolerated with dizziness and constipation as the most common adverse effects. Extensively metabolized in the liver by CYP3A4 and CYP2D6 isoenzymes, and it is mainly excreted by the kidney. Concomitant use with strong CYP3A inducers or inhibitors is contraindicated. So in this slide you can see a summary of different classes of antiarrhythmic agents. So let's go through this. So mainly antiarrhythmic drugs are mainly classified into four classes: class 1, class 2, class 3 and class 4, and the class 1 is further subdivided into three categories: class 1A, 1B and 1C. So class 1 mainly they are sodium channel blockers. Okay, class 1 mainly sodium channel blockers. 1A means they slows phase 0 depolarization in ventricular muscle fibers. 1B shortens phase 3 repolarization in ventricular muscle fibers, whereas 1C markedly slows phase 0 depolarization in ventricular muscle fibers. Now moving on to the class 2, they are beta blockers or beta adrenergic antagonist. They inhibits phase 4 depolarization in the SA and AV nodes. Now the class 3, they are potassium channel blockers. What they will do, they prolongs phase 3 repolarization in ventricular muscle fibers. Now moving on to the class 4, they are calcium channel blockers. They inhibits action potential in sinoatrial and atrioventricular nodes. So we have completed today's session. If you have any doubts, you can comment in the comment section, and please like, share and subscribe. Thank you everyone for watching this video. Have a great day.